Good afternoon, everyone, and welcome to Open Classroom. I'm Janet Gillow, Director of Professional Development for the Brown School, and we are so glad you're here for today's presentation. Before we get started, I just wanted to make a note for you all that we do have a double header of programs coming up on Thursday. In the morning, 10 a.m. Central, we have the second in a series on COVID-19 and race, a wonderful panel presentation discussing the mental health impacts of the pandemic, and then back on at our regular time of 12:30 for Alexis Duncan's presentation on public mental health. So still spaces available. Please visit our website if you'd like to sign up to join. And with that, now I'm going to pass things over to our Associate Dean of External Affairs, Gary Parker, to introduce today's program.
Thank you, Janet, and thank you so much for everything that you've done pulling together this Open Classroom series. It's been a wild success, and we're so very grateful for everything that you've put in place making this happen. And we're grateful to all of you, the attendees who are here. You know, we've eclipsed now the 100 attendee mark, which we know is always a sign of great interest. And we have a wonderful topic for you today: privilege inequity and pivoting to prevention after the coronavirus pandemic. And for that, we need someone who has an expertise in that area, and that would be Associate Professor Darrell Hudson. His research focuses on racial and ethnic health disparities and the role of social determinants of health, particularly how socioeconomic positions and social context affect health and health disparities. He is currently investigating, the data that shows that African Americans, despite bearing a disproportionate burden of physical health disparities and greater exposure to stress, have lower rates of depression compared to white Americans. He has examined perceptions of depression in mental health care among African Americans and investigated comorbid depression and type 2 diabetes in various settings. He also co-directs the Collaboration on Race, Inequality, and Social Mobility in America within the Brown School Center for Social Development, and he holds a joint appointment with WashU's Department of Psychiatry and is a faculty scholar within the Institute for Public Health. With all of those roles and all of those responsibilities, we are so grateful for him spending some time with us today. Welcome, Darrell Hudson.
Thank you so much, Gary, and I really appreciate you for getting through that long bio and all the different complex words that are in there, all things that are probably a lot more flowery than actually are in real life. But I'm very happy to be here with you all. And while it's a somber topic, an important topic, I'm grateful for everyone who's on the Zoom today to share this. So here's my contact information. I like to start with the end at the beginning. So people have questions after this, you can feel free to email me right there with my email address there. And I'll tell you now that what we'll cover in the agenda really can't be adequately covered in 1 hour, in less than an hour. So you should leave here today unsatisfied. You should have lots of questions remaining. You should have lots of different perspectives and things that you might disagree with me or things that you wish I'd elaborated on. So again, you can email me or you can check in on Thursday. Like Janet mentioned before I started, there's a couple of really relevant webinars that will happen this upcoming Thursday. So in the way of agenda for today, I'll cover some key concepts related to equity. At the center of all my work is equity. And so I'll apply those concepts around equity to explain the existing COVID-19 inequities that we've seen. And then I'll pivot, as the title says, pivot to prevention and talk about where should we go from here. So just first, the overall impact of COVID-19. Worldwide, we have an estimated 5.5 million infected worldwide. And that's just a staggering number. About almost 2.5 million have recovered, and approximately 320 worldwide deaths. And we've seen growth, especially over the last few weeks in lower and middle income countries such as Brazil. In the United States, we have almost 2 million cases of coronavirus, 1.7 million, almost 100,000 deaths. And because Memorial Day was yesterday, just to put that into perspective, we lost almost 50,000 American lives on the battlefield of Vietnam. We lost so far over 2,000 service people in Afghanistan. We've lost over 4,000 people in Iraq. And just to put that in perspective, over 100 American lives since January. And it's just a staggering and somber note. So as I mentioned before, I like to begin with the end at the front. And so some resources that I would recommend if you're really interested in equity, I would recommend these resources. And so one is a textbook that was produced by the American Public Health Association Press called Racism, Science, and Tools for the Public Health Professional. This is an outstanding textbook. I happen to have a chapter in it, and I have a chapter in the other one as well, Men's Health Equity. And what's unique about the current COVID-19 pandemic is that men are bearing a disproportionate burden related to death, while women are also doing a lot of the social and economic household duties and supporting their men in their lives. And so understanding how these two things are happening, how racism and especially gender roles are affecting the pandemic. There's some media resources that I think are really important. One that I really like to privilege here is America Dissected. Abdul Saeed is a former director of Detroit, my hometown, commissioner of health. And so he has a whole series that is dedicated to coronavirus. And so going through the economic and the social impacts of coronavirus and all the things that got us here. Another set of media resources that I would recommend, one is the Serial podcast, which is not related to health so much, but it gives you a good sense of how our criminal justice system works in season 3. And then Unnatural Causes, which is a documentary that was produced a little over 10 years ago that in a few episodes really does do a really good job of providing a good understanding of why inequity is making us sick, and gives you hear from some really good experts around the country who explain how these inequities have affected not just individuals who are marginalized, but across our society. I'd also like to point out and highlight a video called Segregation by Design. So there's a book called The Color of Law that was written by Richard Rothstein. He happens to narrate this particular video. 17 minutes long, but for my money is one of the best pieces of, in a short film sort of format, gives a really good understanding why the United States looks the way it does in regard to segregation. In just 17 and a half minutes or so, you get a good sense of the policies and the politics and practices that have essentially made the United States look the way it is. And I think that's really important when I talk a little bit later about social context, especially the effects of racial residential segregation on health promoting resources and exposure to stress and things like that. Some additional resources that I'd recommend here are the Interdisciplinary Association for Population Health Sciences. And you can see the website there. Also the Society for Epidemiologic Research. In terms of beyond academic resources, there's a few things, and just to queue up for the end, you'll hear from Teresa Kuo from the Gephardt Center here at Washington University. And she'll talk about the importance of the census as well as some of the other things that Gephardt has going on. But I'll also point people into the direction of Stacey Abrams, who came up with fairfight.com, which is a voter registration and voter protection organization. And then there's also votesaveamerica.com. So if you're interested in, if you're wondering, what can I do right now when I'm sitting at home and everything is closed? What could I do to go out and help in terms of politics and things like that, getting ready for the upcoming fall election? Vote Save America has some really good directions there. So going into some key concepts. The first thing is, what is health? And obviously we're in a pandemic, so health is paramount. We've probably not thought about health as much as we have over the last 3 or 4 months in any time in modern American history. And according to the World Health Organization, health is a complete state of mental health, mental, physical, and social well-being, not merely the absence of disease or infirmity. But also think about health in terms of, again, social context. What about the social context of health? So it's really easy for us to think about health in a dietary sense. So what do we put in our bodies? Whether we would fill up on a stack of pancakes in the morning, or we go for a bowl of oatmeal like I did this morning. Fresh fruits and vegetables. But we know why we should be consuming fresh fruits and vegetables and getting physical activity on a daily basis. This is what many of our neighborhoods look like throughout the United States. This is a neighborhood in my hometown, Detroit, Michigan. And so if you use your imagination, think about what health promoting resources are embedded in a neighborhood that looks like that. Where do you think you would get fresh fruits and vegetables? Do you feel that you would be able to safely recreate in a neighborhood like that? One thing that is unique about Detroit is that it was absolutely built to last. So you see a lot of these decaying structures, not just in Detroit, but on the north side of St. Louis and other quote unquote Rust Belt cities throughout the Midwest. Here's a shot that I took from Flint, Michigan, and long before the Flint water crisis. Flint was really struggling with social and economic problems, as well as widespread violence in the city of Flint. But again, thinking about health promoting resources, do you think you would find a Safeway or a Schnucks or a Kroger in a neighborhood like those that are found in Detroit or Flint? More likely to find fast food restaurants, proliferation of fast food places, as well as places that sell cigarettes and alcohol. So that affects your diet and your dietary choices. So if you're like me and you crave hamburgers and fries and that's one of your favorite meals, or even if you're interested in consuming vegetables, a lot of times we're consuming vegetables that have, as I always tease my students, disintegration grade vegetables. So vegetables that have been absolutely zapped of all their nutritional resources. But with regard to physical activity, unfortunately, right now we're seeing racism play out live in the pandemic. And in some ways, you're damned if you do. So we've got a very prominent national case near Brunswick, Georgia, with a Black jogger who was shot by some neighbors. And then if you live in a neighborhood like the one to the right here, you can see, where do you get physical activity in a neighborhood like that? And from an early age, if you're a child growing up in a neighborhood like that, do you feel that you can go there and safely recreate? Do you feel that you can go and move your body there? And you can only imagine what types of other activities might happen in a context like that. All that being said, when we think about health in general, health is not happening in a vacuum. Health happens with people embedded within systems. Obviously, we have our individual health, but then across the life course and according with our interactions with the environment, all the way up to social and economic policies, down to institutions, the neighborhoods that we live in, and so on and so forth, all those things kind of come to the pinpoint with our individual health. So again, the importance of social context can't be overstated. Social context absolutely shapes our social norms in terms of what we think might be delicious, what we think might be a healthy way to cope with stress in our lives. You can also think about the opportunities that might be absent in certain neighborhoods. So you might not be able, again, to get physical activity because of safety concerns, crime, or even just the conditions of some of the facilities that you might have access to. You can also think about how social context produces stress. So stress is a really potent, really corrosive thing that we'll talk about in just a few minutes. But social context, again, crime, do you feel safe in the neighborhood? Your connections to other people, all those things can produce stress. Many people talk about social determinants of health. Another way of thinking about social determinants of health is fundamental causes. So what are fundamental causes? Fundamental causes include access to resources to help people avoid diseases through different mechanisms. So again, through your social context, what neighborhood you live in, will have access to different health promotive resources you might have. It's theorized that fundamental causes affect diseases through multiple mechanisms, and they continue to affect outcomes even when risk profiles change. So in other words, diseases can come and go, but the distributions of different diseases will remain relatively the same over time. So you can apply this concept of fundamental causes to the coronavirus. Who was initially the most affected, especially within the United States? People who had traveled. And if you think about the characteristics of people who've been able to have the privilege of traveling around the world, they look a lot different than the people who are suffering the most right now. So fundamental causes, things like racism, poverty, again, the social environment that one lives in, all those things are really paramount in regard to the spread and production of not just health, but also disease. As I mentioned before, many people think about racism as a fundamental cause of health. And the reasons why are many. These are just a few. So there's been many policies and practices within the United States, such as redlining and restrictive covenants, that have shaped the way that neighborhoods in the United States work. There's urban renewal and highway construction that really privileged the creation of the suburbs and the benign neglect of urban centers. There's also strategies and practices called blockbusting, where, again, in that video by Richard Rothstein, Segregation by Design, you can hear about blockbusting as a strategy. There's also steering, and steering still occurs today. Even though steering is illegal, people find ways to tell you about certain neighborhoods without using certain words that are not appropriate to say. And there's also access to mortgages. So there's still data that indicate that for Black and brown people who do have the credit and the income, the resources to afford certain types of mortgages, they're still steered to higher risk products. Here's just a look at what redlining looked like. And you can see in cities like Chicago, still neighborhoods that are outlined in red, hazardous, where banks were not going to make loans for housing and other developments. Those developments were neglected and they were left out, and you can still see the cleavages of those practices today. In cities like St. Louis, and St. Louis is really unique in its segregation. We've got these really beautiful edifices that are throughout the city and throughout the county, but they're designed to keep people out. They're designed to keep certain people out. Some of them, again, are very elaborate, very beautiful. But again, you can see segregation and the very present desire to keep people out. You can also see how racism has affected health through New Deal era policies. And for my money, New Deal era policies are absolutely transformative in American history. Many people see or are exposed to New Deal era policies when you're in, say, 10th grade in US history. But for my money, New Deal era policies absolutely transformed the United States in many different ways. And one of those ways is the GI Bill. So for service people who have served their country, returning to home, they were able to go to college, whether it's a 4-year college or a 2-year school or a technical college, for serving in service of their country. The GI Bill was not equitably distributed by race. So if you were a Black veteran, you were steered to 2-year colleges or vocational schools, which of course didn't net as much income as going to a 4-year school. And especially if you were in the Southeast United States, where most African Americans live, during the very initial unveiling of the New Deal era and the implementation of it, states like Mississippi and Alabama and Georgia did not allow African Americans to attend their state flagship institutions. New Deal era policies also included the Social Security Act. So this is often referred to as our older age insurance. Also established the Homeowners Loan Corporation and the Federal Housing Authority. And those two things together, the Homeowners Loan Corporation and the Federal Housing Authority, ended up making it possible for suburban single family dwellings in the suburbs to cost less than renting a place in the urban core. All this today manifests in immense wealth gaps, tremendous wealth gaps, and you can only imagine what the effects of the current recession might be on wealth. And for many Black and brown people, I would say these wealth numbers are inaccurate because most people don't know how much wealth they have. It's very difficult to estimate wealth. Furthermore, for many people of color who have attended college and graduate school, they've taken out tremendous amounts of debt, I should say, to finance their education. So they're even more in debt than these figures would show. So the culmination of all these different problems, you might say, would lead to consideration of upstream and downstream determinants of health. And to think about upstream determinants, you might see a factory up at the top of this river here. And that factory might be polluting into that water, where that water is flowing downstream and affecting this fellow here who's drinking that water. And you can imagine what types of exposures and health effects there might be from consuming that water. Now, one might say, well, what would be the solution? If I asked you at home, what would be a solution to this upstream problem? You might say, let's stop the factory. Let's get the factory relocated. But there's people who work there. Their livelihood depends on working and being employed at that factory. That town, other subsidiary businesses might also depend on that. So you meet some formidable foes who would say, no, we don't want that factory relocated or closed, or even regulated where the efficiency would be affected. And we can see this right now with upstream and downstream problems. We see that our most effective strategy in mitigating the spread of coronavirus is social distancing. And you can see across the country at different state capitals, people are protesting. And why are they protesting? Not only are they stuck in the house and away from their social networks, they're also concerned about the economy. And for some people, they say, as we've heard throughout the political rhetoric of 2020, is the cure worse than the disease? And as this protester says right here. I think it's also interesting to juxtapose the protests that we see at the state capitals with what happened just here a little less than 5 years ago in Ferguson, Missouri, which is a suburb of St. Louis, and how different protests are perceived. So moving on to health equity. So equity is in the title of this talk. And so what exactly is equity? Equity simply means that everyone should be able to obtain the highest level of health possible and should not be disadvantaged because of their social position or some other type of socially determined circumstance. So striving towards health equity involves creating opportunities and removing barriers in order for people to achieve their fullest health potential. So again, moving from those core concepts, so we talked about fundamental causes, upstream and downstream determinants of health. We've talked about some of the specific policies and practices that have shaped the United States and why it looks the way it does, especially in regard to social context and how social context can be related to health. That will come up again in just a moment when we talk about risk factors related to explaining COVID-19 inequities. So regarding health equity and COVID-19, we know that the pattern of transmission, especially in the United States, has not been equitable. We also know the severity of the cases has not been equitable as well. Vulnerable populations, including people who are older adults, frontline workers, essential workers in general, not just people who are healthcare workers, but also people who are at grocery stores and deliveries, those people are also vulnerable. Homeless people who don't have a safe dwelling, undocumented immigrants and incarcerated people are also especially vulnerable. And we know that from the data that have emerged that Black and brown communities have been disproportionately affected. So examining the disproportionate impact of COVID-19 on people of color, 20,000 Black Americans have died of COVID-19. 20,000 Black Americans. That's 1 out of every 2,000 Black Americans in the United States. Blacks are at higher risk of severe illness, and they're 1.6 times more likely to live in households that have a health sector worker. Among Hispanic adults at high risk of severe illness in households, there's at least one worker who works outside of the home. A recent paper that I reviewed, which hopefully will be published pretty soon, shows that the data just overwhelmingly indicate that Black and brown people are more likely to be essential workers, more likely to be healthcare workers than whites. And again, these things are certainly helping to spread the condition, not just among people who might be healthy, but also looking at intergenerational households as well. So as I mentioned before, employment in essential services and the intergenerational household. So I was raised by my grandmother. So if I was living at home with my grandmother right now and I was working at McDonald's or I was employed as a janitor at a hospital, I could simply just, by the course of my day-to-day, end up inadvertently passing the virus on to my grandmother, who would be older and could, while she might not, my immune system might be okay, hers might not. We also think about overall access to healthcare. So obviously, Black and brown people are less likely to have access to healthcare, less likely to have health insurance. Also, not just access in terms of insurance, but also proximity or where healthcare facilities are located. And also the hours of operation. So if you work from 8 to 5 every day, when do you find time to seek care? And also, oftentimes, if you're not connected to healthcare, it's difficult to get a referral or to know what's the first step if you do feel like you're having a symptom related to the COVID-19 illness. And obviously, people have talked a lot about testing and access to testing. How do you get tested and where should you go to get tested? So again, these are explanatory factors to explain inequities in COVID-19. And as Dr. King will say, it's a cruel jest to say to a bootless man that he should lift himself up by his bootstraps. Even worse to tell a man to lift himself up by his own bootstraps when someone's standing on that boot. And so thinking about, again, the culmination of all these different explanatory factors, intergenerational households, limited access to healthcare, limited access to testing, and an overwhelming being more likely to be employed in essential services, all these things culminate to end up placing Black and brown people at disproportionate risk of COVID-19 cases. Another primary risk factor is stress. Stress gets under the skin, social stress, and is highly corrosive. So social stress is the stress that we feel on a day-to-day basis. That's what stress is all about, being able to pay a bill, but the same sort of activation that happens whether we would see we were fighting or running away to save our lives are the same mechanisms that are activated when we feel social stress, like financial distress. And because of that, a chronic activation of our stress response system is associated with deleterious health outcomes. And stress accumulates over the life course and can accelerate the aging process. And this is even true among upwardly mobile people of color, because a lot of times they have pulled themselves out of poverty. And because of the stresses they may have felt when they were younger, or even the stress to maintain where they've come from, oftentimes you end up with a compromised immune system functioning. And so an example of this for anyone who spent any time in school, there's finals time. And what happens during finals? People start to get sick, especially if you live in a dormitory where there's a lot of close interaction with people. People oftentimes get sick during finals time. So Another major risk factor for COVID-19 cases and the severity of those cases are comorbidity. So these are health risk factors like hypertension, diabetes, overweight and obesity, things like that, that can increase the risk of COVID-19. And recall the importance of social context, however. So if people are not living in neighborhoods where they can eat a healthy diet or they can get access to regular physical activity, then of course they're more likely to be overweight. And the data indicate that about 76% of Black Americans are overweight or obese. And over 60% of Black Americans age 50 or older have hypertension. 23% of Black Americans have diabetes. And if you were to stratify this by age, you would end up with even larger disparities there. But again, these are not naturally occurring disparities. Again, thinking about social context and where people live and what access to health promoter resources they have. So how do we get here? Again, thinking about politics. So politics and political ideology, those things are not oftentimes seen as a social determinant of health, but they absolutely are. In the United States, we often pride ourselves on the fact that people can move here and make it. And if you work hard and are willing to play by the rules, then you can have a really outstanding life. And so there's a great emphasis on individual effort, going back to the origins of this country. And there's an assumption that outcomes are different because of effort and choices, not necessarily opportunity. Oftentimes there's an ahistorical perspective as well. You'll hear people say things like, well, I've never owned a slave, or my family's never owned a slave, and I've worked really hard to get where I have. And those things may be true, but it's not about individuals. We're talking about populations. And so if we don't think about how populations have come to be exposed, again, to differential risk and addressing the historical policies and practices that have placed people of color at disproportionate risk, then again, we've got this ahistorical perspective. And one of those things will be selective socialism. So many people will say that if you looked at New Deal era policies like the GI Bill, the Social Security Administration being established, things like that, that looks like socialism. But there's differential access to those New Deal era policies. And again, you can see the effects of those policies in addition to things like redlining from the private sector. So pivoting to prevention. So we've talked about, again, key concepts related to equity. We've talked about why the disproportionate impact of COVID-19 has been overwhelmingly borne by, and especially in the United States, by people of color, particularly Black and brown people. Now we have to think about, well, where do we go from here? How do we pivot to prevention after this? So next step is simply acknowledge that we failed these communities before COVID-19 came about. As soon as COVID-19 started to spread in the United States, many people like myself who study health equity were immediately concerned because we knew that communities, places like St. Louis, places like Detroit, New Orleans, New York, those places are set up in a way where we have lots of intergenerational households and we've got lots of different people working in essential services. And so there was a ring of the alarm, but again, we've already failed these communities because there's not equitable access to health promoting resources. We should also interpret the inequitable impact of COVID-19 as a societal failure, not individual failures. I think just a few weeks ago, our Surgeon General talked about social distancing and the need to do so, and talked about people thinking about cultural considerations like avoiding or abstaining from visiting an older loved one, things like that. And while those things are important, it's also important to note that some people don't have the option to avoid that contact. If you're dependent on a grandmother for childcare, or if you reside with an older adult, then that's sort of difficult, if not impossible, to abide by some of the social distancing guidelines. I think we should also consider this crisis as a wake-up call to privilege equity. And we should really try to work to ensure that everyone has equitable opportunity to achieve their highest level of health. So those are very broad. What does that mean? In the short term, we should be thinking about ways to adopt a coherent communication strategy, as simple as that. And within that, there needs to be some tailored messaging. And you can see this at different local and state and county public health departments across the country that have figured out ways to tailor their messaging and make it more specific, make distancing guidelines and things like that, hand washing more relevant and to people who live there. We also have to improve access to testing and address basic social and economic needs. So if people are food insecure, housing insecure, we have to figure out ways to address them. And especially with so many people being out of work right now, we've got to figure out a way to help ensure that people can still put food on the table. Another thing that we should be anticipating, and this is kind of a good preview for what I'm sure will be talked about on Thursday in relation to COVID and mental health. So there's increases in mental health conditions, including depression and PTSD, anxiety disorders, substance abuse disorders, as well as instances of domestic violence whenever you have any sort of catastrophe. Also, people are dealing with tremendous loss. So the amount of lives lost in the United States over the last few months is staggering. And especially with not being able to say goodbye to loved ones in the way that we're typically used to, that's an additional loss factor. Physical distancing also, while it's effective in reducing the spread of the transmission of coronavirus, does promote loneliness, promote stress, which again, stress is related not only to the promotion of a weakened immune system, but also stress is related to mental health. So again, depression and anxiety. There's job loss, which again, job loss is a primary stressor, one of our top stressors in any American's life. Moving and family conflict as well. So if people are used to having to move their lives to get support from a loved one who's in a different state, and people are working into, I know this for several colleagues who have multiple adult children and their children in a household, that can be really stressful. So the actual move, then having all those additional people in the house, as well as family conflict. So because of the increased number of people in the house and the demands and stresses, that can make it really quite stressful. And so we have to figure out ways to improve our surveillance systems and reinforce the mental health service systems that we have. I think another way to think about pivoting to prevention is to think about etiology. So how do we get here? Etiology is the study of how certain diseases have occurred. And so there's this seminal piece by Jeffrey Rose called Sick Individuals versus Sick Populations. And he talks about the importance of identifying cases versus causes. So going back to fundamental causes. What are fundamental causes? Again, those access to resources and these things that are really sticky that if you don't address, that a new population will take the place of a high-risk population. He promotes two different strategies. There's a high-risk strategy and there's a prevention or a population strategy. Now, population strategy is radical, has large potential for population. It's behaviorally appropriate. So we're not asking people to make tremendous leaps and feats to change their behavior, but rather we're making the healthy choice the easiest choice. And what you've seen here, especially in relation to COVID, is a prevention paradox. Anytime that you have something that works really effectively, people start to ask, why are we investing in this? Why should we be supporting this? And so an example of the prevention paradox might be vaccines. For a long time, we've been very effective in reducing certain vaccine preventable diseases such as polio. In my adult life, for instance, I've never met someone who had polio or has polio, but that was through vaccines. Everyone gets a vaccine when they're very young. But now people start to ask, well, why do we need vaccines? And should we be doing this? And you start to see, even just over the last few years, these kind of pop-ups of vaccine preventable diseases like mumps and measles in different areas of the country where there's been these sort of waivers granted to avoid vaccination. So again, if you're thinking about big P prevention, if you're thinking about making preventive strategies that are, again, radical and have a large potential for the population and make it less burdensome for individuals, those things are always going to be threatened by the prevention paradox, including things like physical distancing guidelines. And why do we need to make such investments in public health, for instance? There's another strategy that's called curb cut effects. So there's a person who's from St. Louis who founded an organization, Angela Blackwell, called Policy Link. And so she describes curb cut effects as those that focus on those who are most vulnerable. So these are policies and practices that privilege those who are most vulnerable. An example that she uses is if you were confined to a wheelchair and you were making your way down the street and you got to the end of a street and there was no indentation in the sidewalk, there was no ramp, what would you do? So your options will be limited. You can take a chance and kind of go over the curb. You can find a way to circumnavigate that curb, which might add a lot of time. But what if there was an indentation, a ramp? Well, you can get right down that ramp, and that benefits a person who's vulnerable, who's in a wheelchair. But not only does it benefit that person who's confined to a wheelchair, but also would benefit a person who's on a bicycle. If you've ever been on a bicycle before and you've been on the sidewalk, which you shouldn't be, but people do it, you might find a curb there. And again, you can risk it, and you probably don't want to risk riding your bicycle over a curb, but having a ramp there will really help. That curb cut really helps. Same thing if you're pulling, if you're very able-bodied and you're traveling and you have your luggage and you're dragging your luggage down the street. Probably experienced this before. When you get to a curb that doesn't have an indent, you can damage your luggage if there is no curb cut. So again, thinking about ways to focus on those who are most vulnerable can sometimes have a broader benefit for everyone. And the best example that I can point out there would be New Deal era policies. So hopefully pivoting out of the current pandemic, our collective minds in this great country will think about some progressive and universal policies that, again, will make all boats rise. Some other things to think about, especially as we think about overall reducing racial inequities in health, especially in regard to COVID-19. One is alignment of resources. So in a moment, Teresa Kuo will talk about making sure people get counted. So who's at the table and going beyond systematic representation, but making sure that people are there and they have a voice. Another thing that is important in regard to, especially people like myself who are in public health, is science policy. Oftentimes there's a misalignment between what people on the ground really care about versus what is actually funded. And so trying to realign the funding mechanisms to the things that people really care about is really important. Other ways to move the needle would be to think about curb cut policies. And of course, in order to adopt and implement those policies, we need politics. So thinking about communication, so getting people to the polls and getting them to vote, as well as getting people to be counted. So that's all from me. And I just wanted to yield the rest of my time to Teresa Kuo, who will tell us a little bit about the Gephardt Center's efforts in regard to the census and some other things.
Thank you. So I'm going to just switch really quickly to my screen and share some slides. Can you see that okay? Okay, great. As Dr. Hudson mentioned, I'm Teresa Kuo. I work at the Gephardt Institute for Civic and Community Engagement at Washington University. So I wanted to just go through a few things because I think it's really important to think about what are some of the actions that you can take given gross inequities that we're experiencing in our country and in our world. It can feel really, really big, and there are opportunities that we have to take small steps to move that needle. So just really quickly about our institute, our mission is to foster a vibrant culture of civic engagement across WashU, and this is through educating students, catalyzing community partnerships, and then infusing civic engagement throughout WashU. Most of our work happens at the university, but we also do a lot to help cultivate partnerships between university entities and community organizations in the St. Louis area and across the nation. So one of the things I wanted
forgive me for interrupting. Could you just put your slides in presentation view? We'll be able to see them a little better.
There you go. Thank you.
Not quite. This is presenter's view, so we can see your notes and everything on this.
Oh, strange. Okay, let me close that out. Let me try again. Did that work?
Now it did. Yes.
Okay, great.
Thank you so much.
Yeah, thank you, Gary. So one of the ways that we can do this is making sure that we're counted in the census. So it seems like it's really a small thing, but in fact it has major implications for resource allocation, political representation, etc. A great and relevant example of how census data is used in impacting our day-to-day lives is the CDC actually uses census data to make determinations about how vaccines get allocated and distributed across the country. So things like the flu vaccine, et cetera, they're thinking about where are those populations, how do we send that out and distribute it across the country. In Missouri, in the 2010 census, it's estimated that we lost $1,300 in federal dollars for every Missourian that was not counted. And so you can see that there's a lot of funding that goes to programs that are really helping to support some of those things related to social determinants of health. And this is even more critical for what are called hard to count communities. So that's low income, renters, people of color, young children, immigrants. It's estimated that 9% of the population of Missouri is living in hard to count communities. And I imagine that that is only larger given the changes in population in 2020. The other thing that's different about this year's census is that it's now available online, and that's going to cause hardship for roughly 20% of Missouri's households because of lack of access to broadband and other issues related. And now that we're all conferencing on Zoom, it only makes that broadband much more difficult to access. So I want to just make a plug to make sure that folks get counted. The Gephardt Institute has curated all of the census information that's important for some special communities on WashU's campus. So whether you're a student who lives in a dorm, international students, or students studying abroad, there's information that can direct you to how to complete the census. If you on this call have not completed the census yourself, you can go and do that online at my2020census.gov. The other thing that I'll mention is it's critical that not only do you get yourself counted, but think of yourself as a leader and messenger to make sure that your friends, family, neighbors, and all those that you interact with get counted. The deadline has been extended, so you can still complete the census today and through October, I believe. All right, and so a few other additional resources I want to mention. We have our Engaged Democracy Initiative, and a big part of that is around voter engagement. This is a critical way of getting your voice heard. We are doing our very best to make sure all of our students are registered and that they turn out. We have purchased and subscribed to this tool, wustl.turbovote.org. You do not have to be just a WashU student to be able to use it. We partner with the Center for Social Development and Dr. Gina McClendon out of the Brown School to also provide this tool to community residents as well. But it can direct you to voter registration sites in all 50 states. We also have Common Ground grants available if you're interested in promoting dialogue across ideological differences, a workshop series. And then our Civic Engagement Fund is the last one that I want to mention for course development grants, St. Louis project grants, and then small change grants. These are mostly directed at WashU community members, but should and can be in partnership with people in the St. Louis community. So if you are not WashU affiliated but work with someone who does, they can fill and complete the fund requests on your behalf. So that's all I wanted to share related to some resources quickly. I'll actually turn the floor back over to Dr. Hudson because I saw some really great questions that'll take some more meaty discussion.
Thanks so much, Teresa. And yes, absolutely, there are some great questions that came out through the dialogue. Thank you both for the presentation. Darryl, the first question that we had from several people was, can they have the slides? Would you be all right sharing this on our website?
Yeah, absolutely. I will be perfectly fine sharing the slides. And again, if people have additional questions, I'll just put my final slide there so people can find me and email me. But absolutely, yeah, they can certainly have the slides. So I'll send those to you, Janet.
Great. Okay, and so diving into some of the other questions, Nikki is a school psychologist and saying headed back to school in the fall. What would you advise that she focus on first to help her, the Black and Brown students, either individually or on a school-wide basis?
Yeah, sure. That's a really great question. And again, thank you all for, I saw there was over 100 people here. So thank you all for your attendance and your interest, and people, especially like the questioner here who's doing this work on the one-on-one basis with individuals in schools is really important work, and I can't diminish that. In terms of what to do, I think that first things first is health and making sure that we're safe and that we abide by the public health guidelines at the time to make sure that if we do open schools in the fall, that's in place. I think it's also a good idea, and the questioner probably knows this better than me, to check in with students. I think we have to do a better job of supporting not just teachers, but the entire school system to make sure there's adequate resources. So people who may be food insecure right now, who may be dependent on schools for food, also people who have intellectual disabilities and things like that. We have to make sure, again, if we're serious about equity, that we are making efforts to reach those who are most vulnerable and privileging those folks first. So those are just a couple of ideas that come off the top of my head. I'm sure people who are in education who are much smarter than I am and who are thinking about educational policies in relation to COVID are thinking about this in a more nuanced manner than I am. But those are just a couple of things that come to the top of my head.
Thank you, Darryl. And first, just a commentary. There are few people in the world who are as smart as you are, Darryl. And I can say that after having known you for many years, and I'm just so grateful to have you here. When I saw the title of your presentation, and it started with privileging equity, which I thought was a really interesting term, because usually when you think of advancing equity and you think of privilege, you see them at odds with each other. Can you tell me a little bit more about your thinking behind privileging equity?
Sure. So I think that, again, in a crisis situation, and make no mistake that we are in a crisis that we have not seen in our lives. It's been over 100 years since the last global pandemic. And so we really are in a crisis situation, and people are rightfully really concerned, oftentimes really scared. It's had a tremendous impact on the economy, and the toll goes more and more. So every day we learn more and more infections, more and more deaths. So all that being said, I think the reason why I think about privileging equity is that in the face of all that crisis, it's really easy to forget about inequity. It's really easy to not pay as close attention. And even with the data that indicate that there are people who are bearing a disproportionate burden of this condition, there's still sort of I don't want to call it lazy, but sometimes a misinformed way of framing why these inequities are occurring, oftentimes defaulting to say it's about genetics, or it's got to be about poor choices, or people are now listening to distancing guidelines and things like that. So just making sure that we pull away from that type of characterization of people, again, who are vulnerable, oftentimes people who are in thankless jobs. So people who are cleaning the hospital rooms, who are providing our groceries, who are providing our food. Those are really some unsung heroes here. I think to lift up those people who are disproportionately suffering from this is absolutely critical, even in a crisis situation.
So Damon has a question. Given the issue described with men being most vulnerable during this crisis, how do you reach men effectively and help them prioritize health? He's interested in this both at the individual and the population level.
Yeah, sure. So I think part of it is thinking about how, so in terms of tailoring messaging to people, and oftentimes thinking about where people are working. So if men are more likely to be in certain fields, certain occupational fields, making sure that we have adequate personal protective equipment, which there's varying data that indicates that some people feel like they have adequate access, some people don't. Making sure that people have adequate access to testing. I also think it might be important to think about things like hazard pay, for instance, as a way to make it, to reward the people who, again, who are the unsung heroes, who are really keeping our country running right now, who are behind the scenes. So those are a couple things that I think in relation to men. I think it's also important to think about women who are behind the scenes as well. So women make households run. And if there's a sick man in the household, they're taking care of that man, they're taking care of the kids. And so there's a gender inequity that's going in sort of opposite ways. Men might be more likely to die from the disease and be more likely to contract the cases. But women are also doing a lot of the work that's happening. So I think we have to figure out a way, again, in terms of equity, and equity doesn't always mean you give equal amounts to different groups. We have to think about ways to privilege equity so that men get benefits in certain ways. Again, maybe that's through hazard pay or something like that. And also making sure that women have adequate access to resources as well.
Really terrific, Darryl. I want to give you an opportunity to, and Teresa as well, for some closing comments, and then Janet will help us sail out.
Sure. Again, I thank everyone who's been here and shown your interest, and really surprised to see so many people stuck on all the way to the end. And again, thank you all, and I hope that you're healthy and safe and well where you're at. And I would say the biggest thing to me will be we have to vote. We have to vote this year and make sure that our voices are heard. If you're not happy with the response, I'm not happy with the response. We have to do a change. We have to make a change. And so that's what I would say.
Yeah, and I would just echo that and say that the state of Missouri's legislature passed late in their legislative session a bill to allow absentee voting for no reason for this year. So if you don't want to risk your health by going out to the polls, know that you will be able to vote absentee for the elections this year.
Very important. Thank you both so much for this content. Darryl, I am not surprised people are interested. This is, as you say, a crisis, and there's a lot of people trying to understand it and figure out what we can do and what we can do better. So thank you so much for these resources and making them available. We will post them to the Open Classroom on-demand resources, and you'll see them there within a day or two. Thanks also to my handsome co-host, Gary Parker, always a pleasure. And hope to see you all back on Thursday. As mentioned several times throughout the presentation, we have 2 programs that are also relevant to this topic, and we would love to include you in that conversation. So until then, I hope you all stay healthy and safe, and thanks for joining us on Open Classroom. Bye now.
Thank you, Darryl. Thank you, Teresa. Really appreciate it.